Good afternoon, everyone, and happy Earth Day. I'm Andrea Solomon, and on behalf of the entire Development and Alumni Relations team, it's my privilege to welcome you to our first webinar in the Choate Connects Us series. We created this series to keep the greater Choate Rosemary Hall community connected during this time of social distancing. Keep a lookout for future panel talks on education in these challenging times, featuring the president of Middlebury College, who is an alumna, and our head of school, Alex Curtis. Also coming up, a discussion on COVID-19's impact on sports with the former CEO of IMG Sports, an International Olympic Committee board member, a Fox Sports executive, and acclaimed sports writer, all Choate Rosemary Hall alums. Today, we're going to have a conversation about COVID-19 and speak with three experts about the way in which government at the national and local level can address this pandemic. Today's discussion will be moderated by Geoff Cowan, a member of the class of 1960. Geoff is university professor at the University of Southern California, where he leads the USC Annenberg School's Center on Communication Leadership and Policy. If you have any questions during the discussion, please write them in the questions area. And if there is time, we will pose a couple of them for the panelists. Welcome, Geoff.
Thank you, Andrea, and welcome to all these Choaties or Choate parents or whatever your connection is to Choate. It's kind of amazing to think that there is something like 350 people, maybe more, tuned into this discussion, which is more people than I think fit in the chapel when I was there, probably more than there were in the upper class classes while I was back there. And actually, one thing I was wondering is about dress codes. I don't know what the dress code is today, but we're all learning sort of go to meeting and Zooming dress codes. Marna's in a actual professional setting, but I'm in what I consider to be a Choate dress code at home. Please do send questions to her if you have them. We hope to have a little question at the end, time for questions at the end. I'm thrilled to introduce this terrific panel, and what I'm going to do is to introduce all three of them and then there'll be a question for each of them. And then at the end, I'm hoping we'll have a good discussion between us. But first of all, Tom Bossert. A lot of you watched Tom on ABC. He's here thanks to Chris Glasto of the class of '84 and his colleagues at ABC News. So thanks to Chris for this. Many of you know about Tom's remarkable background in government. He was Deputy National Security Advisor to President Bush, later Homeland Security Advisor to President Trump, and in 2017 called for a comprehensive biodefense strategy against devastating pandemics. He's now ABC's Homeland Security analyst, and we've asked Tom to discuss how and why the U.S. can, should, does, and did prepare for pandemics. When Tom and I talked about this before, he sort of saw himself as his job as being the risk analyst for the U.S. government, and there's got to be somebody, and pandemics are obviously one of those gigantic risks. Second guest is Jon Samet. Well, he was kind of a Choate when I was, and we were also at USC together. Jon, it's great to have you here. And Jon's career started looking at the health risks of inhaled pollutants. He's now the dean of the University of Colorado School of Public Health. But he also comes with another very special role in this in breaking news, which is that he's a top advisor to Colorado Governor Polis, who's made a major announcement Monday about that state's plans with regard to the next steps in dealing with coronavirus. And so we asked Jon to discuss the science of coronavirus and pandemics generally, and what Colorado is good doing, and maybe a little bit, Jon, that'll be related to how we think about how other states do it. And our third guest is Marna Borgstrom, and we're all busy, but you're the busiest, it seems. In fact, you're even in an office right now as the Chief Executive Officer of Yale New Haven Hospital and New Haven Health, also the parent of two Choate students. And we've asked her to discuss the view from the health professions and the hospitals. And after hearing from all three of them, I'm hoping that we'll have enough time to get the three of them into a conversation about what they see as the next steps of what's going to happen, and a little bit of questions from the audience. But again, thank you all for being here. Thank you for the listeners and viewers who are out there, 350 of you or more. And let's start with Tom Bossert. Tom, can you hear us? Well, we've been having some technical problems, and
No, Geoff, this is Tom Bossert. I can hear and see you. thank you for that kind introduction, and apologies that you can't see me. I'm suffering the same work from home syndrome that accompanies this virus.
I've said to everybody is they should, if they want to see you, they should see you on ABC News. If they want to hear you, they should listen now.
Vlasto is very happy. I appreciate that. I will fix this at some point in the course of our conversation and multitask, but thank you for allowing me to start. This is a real honor to be invited. And I think, given that there's a lot of people on the line, I'd like to address the first comment to the students at Choate. And I say this quite sincerely. Almost all of our federal governments and our state governments planning for this type of low probability, high consequence event started from a curricular or extracurricular reading assignment. And that is a reading competition that started between then President Bush and one of his senior advisors. And so for anybody that thinks extracurricular reading isn't important, President Bush read a book by John Barry on the Great Influenza of 1918. When he completed that book, he came down from the residence and told my then boss that he was very, very worried that we weren't prepared for this if it were to happen again, and insisted that we not only develop a strategy, but all the implementation plans and budgets and back office capabilities necessary for this potential day. And so therein started the tasking. And I thought that might be an interesting way for us to frame it. There's a whole lot of higher order risk management conversations that we can have about how to dedicate resources. Often there are competing immediate needs that outweigh the potential future low probability events, but that kind of calculation is very important. But leadership and reading started this, and I thought I would start the conversation today with it.
Thank you for that, Tom. But maybe you can then move from here to the higher level question of how do you think about this at the federal level, because you were, how do you think about how to prepare for something like this, and what do you do when it actually hits?
Well, one of the things that happened was a realization that the basics weren't in place. And so in 2005, we set forth to develop a strategy that would address the deficiencies in our capabilities and capacity to develop vaccines, medical countermeasures, basic rules of the road for who might be in charge and who might be a supported and supporting command and so forth. And then we realized that the implementation would require a lot of detailed planning. And we set out in 2006 to develop that plan, to implement such a strategy. And in 2007, something very interesting happened. A number of very smart people came together. And this is a principle of planning. None of us know everything. And I think that's important for leaders and participants of this in this crisis today to remember. You surround yourself with smart people with different backgrounds and education levels, different experiences, specialties, and you ask them to tackle these difficult problems. And we did that with a group of doctors and epidemiologists, and lowly me at the time, who was really an emergency and crisis manager. And I learned from them at that time. And what we did is we decided to go back and challenge the assumption of the past that the outcome of the 1918 flu was inevitable. And we discovered that it wasn't. And there was a data aggregation problem that persists to this day. We tend to talk about the United States as a monolith, and we add what Dr. Samet will talk about as his numbers and trends in Colorado to the numbers and trends in New York, and we end up diluting New York and increasing artificially Colorado when we do that. And so the team then began to do a historical study of the different actions and steps that 43 different states and cities took in 1918. And what they discovered was it wasn't a tale of two cities, St. Louis being the best and Philadelphia being the worst, but a tale of many cities. And they each took a different recipe and approach: timing, duration, layered strategies of closing different public gathering places, schools, taverns, and so on. And what we discovered is that they had positive outcomes, and that the duration and mixture of those approaches mattered. And as a result, it wasn't inevitable, and we should just roll through the next pandemic and take it on the chin, but instead controllable if we acted early and in a localized fashion. And that became, I think, the revolutionary breakthrough that challenged the orthodoxy and set us on this social distancing path. And that 2007 document had another unique quality to it that I'm quite proud of. All of its authors and even minor contributors like myself decided that we shouldn't put names on it. The primary authors took a real risk in doing so, but they decided to just put the seals of their of their government department or agency on the document, not their names. So I'm quite proud of that. I'm proud of them for making that decision. It took on a lot more credibility in so doing. And we are implementing that strategy today of social distancing. And I guess the reason it's relevant to walk through that isn't just to answer your question. It's to point to and hopefully set up Dr. Samet in his presentation today. What I think our audience needs to understand is that the design going into this was supposed to be early localized action. By not understanding how to identify or ascertain cases early enough in a I guess dependable way, we were left with no choice but to modify that plan and implement a blanket nationwide set of social distancing guidelines. And if I were to draw a gruesome comparison to medical science, that's kind of the equivalent of cracking open the chest of an exsanguinating patient and clamping the aorta. You can't keep that aorta clamped very long, and the economy will die if you do. So we have to find a way to quickly release it, and that's the competing tension we're facing now. But it is not an ad hoc thing to release that tension in a localized way. In fact, that was the design going in that we had to abandon, but we need not abandon it as we come back out. And so the plan was a little leadership, a significant tutorial in risk management budgeting, a whole lot of hard work, a lot of experts and specialists, and then a lot of, I think, attention and detail. And in 2007, that seemed revolutionary. By 2017, when I came back into government service, what we did was update it and put it into today's terminologies and really didn't do too much to those fundamentals. That might be a better answer.
There's one other thing I want you to maybe touch on before we move to Jon, and that is, we talked about this some. Part of seeing patterns is a little bit of, I don't know, maybe guesswork is the wrong word, but you don't always know what the patterns really are. And maybe you could describe that for a second, because the earlier you see the pattern, the better, but the pattern may not have fully materialized yet.
Well, there's a number of stories here. There was a Man Gulch fire, one of the early fire jumper experiences, where they had a significant military background and training, these early groups, and they jumped into a fire and they decided that they would put the river at their back and fight up the hill. And that way, if the fire overwhelmed them, they could fall back into the river and that would be their safe exit. And two things happened. The fire jumped behind them in a way they didn't fully predict. So they were trapped between fire approaching up the hill and fire burning in front of them. And they did two things. This has a bad outcome. This is unhappy. Most of them didn't survive. But they all held on to their training and they refused to drop their heavy tools because they were trained to not drop their tools. They might save their lives. And so as they ran for their lives up this hill and away from an advancing fire, they held on to 60 or 70 pounds of metal. And that's a tragic lesson here. That, and in this particular instance, I think some in the public health community, including Dr. Fauci and the advisors I still rely upon, did see a pattern emerging that was outside of what they expected. And they didn't have perfect diagnostic test results, but they knew then that they had indicators on these syndromic sensors, the Sentinel system that reports flu-like symptoms, for instance, that we were seeing unexplainable upticks in patterns in places like New York City. And given the underlying background of a growing epidemic that was soon to become a pandemic and an unexplained new pattern developing, I think it would have been ideal if they could have dropped those tools and improvised a bit. And instead of relying on what they came into the fight with, which was the expectation that diagnostic tests would be available in a timely fashion. And then they did a second thing, and one of them was really commended for this, and he saved a lot of lives moving forward. He knelt down, stopped running, and lit a fire in front of himself. So he improvised on the fly, and all the rest of the people following him thought he had lost his mind. But what he did is he set a fire in front of himself and eliminated the fuel in front of him, and then stood in that burnout ground. And by the time the fire behind him caught up, he was safe. That's a standard practice in firefighting now. But at the time, he was making it up on the go. And so I would contend that a lot of public health officials saw these patterns developing didn't necessarily want to improvise into other solutions like syndromic surveillance rather than diagnostic surveillance. But that's something we can all assess later. The pattern was clear and it was there. It doesn't necessarily mean that we all would have improvised together in a way that we'd have all followed. So I suspect that even with the warning, New York might not have adhered to a social distance set of guidelines before they started to see sickness around them, or they would have thought that anyone that did was that crazy man on his knees lighting that fire at the time. So I'm not prepared yet to indict anyone in their failure to improvise here, but that pattern analysis was pretty clear by mid to late February.
Thank you, Tom. Jon, I don't know if you're still with us. I hope you are. I can't see you now. I can only see Marna. Jon, are you still with us? We lost Jon Samet?
It looks like we've lost his camera. His mic is still on. Why don't we jump to Marna?
Jon, can you hear me? Can you speak? I guess we'll go to Marna and we'll hope that Jon can come back on and we'll all just think, Tom, this is all about improvising.
Yeah, well, that's right.
Marna, you're on the front lines there. In the end, it's in your hospitals. It's thinking about at the local level. Could you describe a little bit what in fact is happening and how you're preparing for it and thinking about it and what we're seeing?
Sure, and just as a little context, so we operate 7 hospitals and about 250 outpatient sites from Westchester County, New York, through to Western Rhode Island in Westerly. And we have a system-wide incident command capability that we stood up before for other things like hurricanes and bad snowstorms, never anything for this length of time. Excuse me, never anything like for this length of time, but it has served us well because it identifies people in all areas that need to be participating and preparing for a pandemic like this. And we had no idea what level of demand we were going to get, what we were going to see. The models that came out of the University of Washington initially, and then others that were reproduced, suggested that in the state of Connecticut, as an example, we had 5,600 licensed staffed beds, and we were going to need 10 times that number of beds by the end of April. And so when we're sitting around the end of February, beginning of March, looking at that, it's unfathomable to think how you're going to stretch the healthcare system to meet that level of need. And we spent, I think, in retrospect, probably a little too much time trying to figure out if and how you could increase the capacity. You can increase the capacity in some ways. You can find big open spaces, you can put beds in place, but if you can't staff them, it doesn't really much matter. So we early on started focusing on how we could mitigate the impact of this disease so that we didn't end up having to create that kind of unfathomable capacity. And what we have seen in our health system is that the demand, the patient demand, has followed the commuter patterns out of New York City. The first hospital in our system that was most impacted was Greenwich Hospital, right on the border with Westchester County. One of the original cells that gave rise to the New York experience was out of a religious community in New Rochelle. The pandemic didn't recognize that there was a state border between New York and Connecticut, and so Greenwich Hospital, which is only licensed for about 200 beds, ended up with about 130 COVID positive inpatients and had to double its intensive care unit capacity, needed more ventilators than they had, and staff. The benefit of being part of a system is that we had less demand initially in New Haven and out in New London, Connecticut, so we were able to move staff, we were able to move equipment and get it where it needed to be. So today, in the original models that came in to us, we were supposed to be at peak demand by the end of this weekend. Today we have about 800 COVID positive patients in our healthcare system inpatient area. About 450 of those are at the academic medical center, and about 160 of those are in intensive care units. And of the ones in intensive care units, about 130 are on ventilators right now. We have moved all of our patients out of the Smilo Cancer Hospital, where we had negative pressure rooms, and created expanded inpatient capacity so that we can safely take care of these patients. And the good news is that while we've had a number of deaths in the time that we've been treating COVID positive patients, we've also successfully discharged either to home or to long-term care facilities 1,000 patients.
I want to continue with that, but just Andrew, if you're there or your IT people are, Jon Samet has texted me that the internet in his neighborhood in Colorado has gone down. Why not? We're all having these crises. And he's asked the question, can you call him? So at least you can get on audio. Can you do that? Do you have his cell there?
I don't have his cell.
Please forgive me, the rest of you. I'm about to now give everybody his cell. Let me see if I can do this here. I'll send it to you. I'll send you his cell while Marna's still talking. Marna, could you talk for a minute about also the economics of the hospital system? Because while this has all been going on, you have not been taking elective patients, and I know out here at least, it's been devastating financially for the hospital.
Yeah. So, I talk about maybe two things that we've experienced, and the economics are one of them. But one thing is, I've been in healthcare for over 41 years, and the one thing that I know is that there are no finer group of people who come together in a crisis. And about 4 weeks ago, we didn't even have a COVID-19 call center. We now operate a COVID-19 call center that has had over 60,000 calls since we stood it up about 3.5 weeks ago. We have the ability to do live televisits for people who think that they're symptomatic. So the kind of can-do, the ability of people to do what needs to be done is remarkable. The stories yesterday, I rounded on 5 of the COVID inpatient units. The patients are really sick in general. They are older, and the staff is extraordinarily stressed because people are doing this day in and day out and worried about themselves and their families and how they're impacted. But they keep coming in and doing it, and I think that the care that's being provided is remarkable. Two of the things that I think are sort of silver linings when we get through all of this, how can we bend the healthcare cost curve? I've observed 2 things that I think are noteworthy. One is it was very hard to get people to embrace televisits. Many of us, not in our children's generation, are still of a mind that you need to be able to see somebody. Doctors like to lay hands on people. And what we have found is that when it becomes a necessity, both clinicians and patients really like telehealth. It gives them much more immediate feedback and engagement with providers. And I think that that may allow us to avoid a tremendous amount of ambulatory site development if we can actually maintain that. And it's not just for the worried well. This has worked very effectively for post-liver transplant patients and others. So there's a lot of work being done in telehealth. The second is if you came in January or February, any place in the Northeast, but any of our hospitals, the emergency departments had patients in every available hallway space, every available bed. We were overrun. It was not unusual to come in the morning and find that at least 3 of our hospitals, they had close to 100 inpatient admitted patients in the emergency department, and you couldn't find beds for any of them because The beds were all full upstairs, and so you effectively turned the part of the emergency department into inpatient units. When I rounded in the emergency department last Friday, there were many open treatment spaces and nobody in hallway spaces. What's happened when you talk to emergency departments here and elsewhere is that the worried well are not coming in anymore, and the patients who are in the emergency department really need to be there. So I think those are two things that are coming out of this that may help us change. The big impact is going to be getting back to business as usual when our business model has been decimated. So what we've had over the last, we were operating throughout the system at a level of about 92% occupancy, probably from mid-fall through February. It was a constant process of trying to reroute and move patients where they needed to be, but very rarely did they get there on the first try. When you're that busy, you become terribly inefficient. At the same time, we still live in a healthcare system where we get paid to do things to patients. So if you have that many patients in, your revenue is relatively high, your expenses are high because you're staffing at a higher level, but the business model in the current environment in which we operate was working pretty well. What's happened in the last 6 to 7 weeks is we have, most people say budget, what budget? We have spent far more money than we had budgeted to spend. We have stood up call centers, we have stood up special units, we have improvised additional negative pressure rooms. We have staffed up for very ill patients. And we are doing no elective procedures, which is in general the only thing that we made money on. So that if you look at it, trying to create a balanced portfolio among payers and services, in very crass terms, those that were profitable were needed to support the mission-driven services. We have, at the end of a full month or 6 weeks of doing this, we probably have lost $300 million. We operate with a $5.5 billion top line revenue. You trend that forward and can't figure out what recovery looks like and how well we're going to recover. We will clearly, our operating margin in a good year is $200 to $220 million. So we are going to be losing money. The question is how much. And I think that that's true of every organization that has done the right thing, which is to take down electives so that you didn't use personal protective equipment. You didn't then put staff at greater risk. And, you know, it's what you have to do, but the business model going forward is going to be very challenged.
So it's a fascinating time because, you know, we all are seeing this happening. For example, the big story today about how department stores may be over. And so many things are going to change. I'm sure things will evolve that are great, and you're suggesting a couple of those too. I think Jon is trying to call in, but Andrea, he may not have succeeded yet. Has he or not? If Jon hasn't succeeded, Tom, do I still have you?
You do have me. I'm still here, yes.
So Tom, maybe you could talk a little about, I think, you know, from you're in the crisis business. This is a big crisis. It's maybe one of the biggest we've ever faced. It certainly compares to a huge war. But what do you think are the things that you learn from a crisis like this? And what are we learning now, and what will we be doing moving forward with it?
Well, we've learned, we've learned a lot, but I think on the pleasing side, because we all hear a lot of negative, on the pleasing side, I've been very pleased to see through positive application and mistakes how tried and true principles of crisis communications and public trust work and don't work. And what I mean by that is when people are reported and they're doing bad things, and we see people just dismissing this on the news, we tend to lose faith in humanity. But we do see significant evidence of by and large, large scale compliance with the recommendations. And I don't think I really thought in my heart of hearts that the entire United States would actually do what we're doing. I always hoped we would. We planned for it. We spent quite a bit of time arguing about it back and forth and the implications to our macroeconomy. And by the way, on the macroeconomy, the cost of allowing this to achieve herd immunity, so to speak, is so devastatingly expensive in terms of human loss, but also economic loss, that you have to always remember to compare the loss we're suffering today with the loss that we would have suffered, and it would have been larger. And we didn't just speculate; we modeled it.
Can you find a way, Tom, to put that into terms that we can all understand? Because certainly part of the dialogue is you don't want to kill the patient while you're, curing the, particular illness or whatever it is. But you're suggesting that the alternative might be to kill the city or something. So what are those numbers like, if you have them?
Sure. Well, there's an economic assessment that was performed in 2007 and 8 of the strategy itself, and I don't have the numbers at my fingertips, but the thrust of that economic assessment essentially confirmed the notion that at a macro level, and by that I mean, imagine not 40 or 50,000 dead, but the larger numbers that we've discussed, whichever ones you subscribe to, 200 to 400,000 or upwards of 1 million people. What happens if public figures choose not to acknowledge a threat that is killing people at that alarming level and rate? And we've seen this principle, by the way. People take matters into their own hands. And when you don't give them something to do, they give themselves something to do, even if it's illogical. And proof in point, we all hoarded toilet paper. That was not a logical thing for human beings to do. But at that point in time, no one had given them anything to do. They had simply said something bad is happening, and they assigned themselves something to do, and the principles of economics and hoarding and so forth played out. That's a pretty common thing to expect. However, had we gone and taken that extreme further and not given any guidance through the duration of it, the level of death would be greater. The overwhelming conditions just described by Marna would have been worse in more hospitals, and not just the ones we see on TV. And society would have lost more in a macroeconomic sense than they've lost to date, believe it or not. Now, in a micro sense, that doesn't help a guy that runs Murphy's Bar, who lost out on his St. Patrick's Day parade income. That is not retrievable income for him. He might have made 20% of his yearly income on the St. Patrick's Day weekend, and he's in dire straits. So I think one of the problems here is aligning incentives and understanding the principles at play. It's been very difficult to communicate 16 years worth of thought and preparation to leaders overnight, essentially. And I think, case in point, they named the first economic stimulus bill a stimulus bill. It's not a stimulus package. This was not meant in some Keynesian debate to stimulate the growth of our GDP. This was meant to align incentives so that the man who needs a paycheck can stay home, because a paycheck is a pretty strong motivator for him to leave and go to work. And if you're gonna align his incentive to stay home, you have to give him some money. And that was the idea. And we ran out of money. We underestimated that. That's kind of the storyline here. We've been 2 weeks behind instead of 2 weeks ahead in our reaction to, instead of our anticipation of this.
Well, and Tom, you tell me, if we had started the whole all of these containment, stay-at-home things 2 weeks earlier, it would have made a huge difference too. But let me just, Andrea, do we have Jon back with us or not?
Not yet, Geoff. He's trying to dial in just via audio.
So why
Geoff,
don't go, Tom, sorry.
Geoff, let me explain what I mean by that. So the idea of doing a localized set of non-pharmaceutical interventions would have allowed us to essentially contain the economic costs to those local areas as well. And the idea of having through factors that were not about fault and blame, but the inability to ascertain cases in a way that the authors of that strategy assumed we would be able to do. The idea of this is that it put us into a massive economic tailspin. It was for a good public health purpose, but the cost of the economic consequences has been greater than the planned public health interventions. And so that's what we have to account for, and that's the intervention dilemma. But it's not a criticism. In fact, it's meant. I was hoping Jon would jump in right on that note. I don't want to.
Jon,
I'm here now.
Yes, welcome back, Jon. And we only have about 10 more minutes, and we want to be mindful, particularly of Marna's time. But Jon, welcome back.
Thanks. What a time for the internet to crash. So.
I specifically want you to tell us also about Colorado, because you have just done this analysis of Colorado and come up with a plan for this stage.
Okay, so let me chat briefly about an awful lot of work of the team of us working here in Colorado with the State Health Department and the governor's office. What we've done is develop a Colorado-specific epidemic model, and I think probably most of you know there's lots of models out there, some general, and what we said is we want something that it reflects our state, that builds on the state's data and the state's population. So that's the tool we've been working with. We continually refine it. And what we did most recently is look at scenarios of what could be done that would allow people to get back together, to start, as I said, to reduce the degree of social distancing, and particularly begin to get people back into workplaces. So we've looked at scenarios where we allow some return to normalcy. The governor's announcement Monday was to let 50% of people back into workplaces, and some other measures. It's not that the state is completely opening up. It's not bars and restaurants. When we look at what happens with this kind of change, we also look at everything else we're implementing. So case identification, there we need the testing, contact tracing, isolation of infected individuals, and also use of masks. And I think probably particularly important is strong recommendations that those who are in the vulnerable groups, 60 plus, with underlying diseases, take care. The governor's built this safer at home, which is a good way to describe it.
Andrea, I do want to, Marna, I know has to leave at the hour, and I think we want to be mindful of our viewers or listeners, and we are too. Are there any questions you want to pose from the audience?
Yeah, we do have a couple. Let's see. Well, one is, should we be concerned about a second wave?
Let's talk about that. Jon, do you want to just comment on that, and then I'd like to
Sure.
Too, and then you can begin to get ready to go. I'm sorry for you taking your time, Jon.
So I think everything we know about the virus, the course of the infection, the fact that our social distancing measures have worked means that most of us are still susceptible. So unless the virus decides it doesn't like hot weather or something else unexpected happens, we are still mostly susceptible, and a return would be inevitable from all that we know.
Marna, you have to be thinking about that in a very practical terms. You told me you lost $300 million. I'm still going to, even though it's a $5 billion budget, that's a lot of money.
A lot of money, yeah.
And so how do you think about the possible next wave?
Well, so what we're concerned about is we think that we're going to get to sort of to a stabilization level, hopefully this summer, where it won't go away altogether, but where we will have many few patients. But all of the models that we're looking for that worry me the most is that we will start to see a rise in the late fall and the beginning of 2021, concurrent with the usual flu epidemic, which usually also puts a lot of pressure on emergency departments and inpatient beds and people who are particularly vulnerable. And the combination of the two is going to be very challenging to deal with, particularly if we don't have a vaccination by that time, and not knowing where we're going to be with antibody testing and the plasma trials that are being done. It's the challenges of treating these patients is going to be enormous, I think.
Let me ask each of you to sort of make a concluding remark about knowing the kind of audience that you've got of parents, alumni, and ultimately, at least on tape, students, things to take away from this moment that they should know. Marna, why don't we start with you, knowing that you've got the hardest stop here?
I think about this. My sons both went to Choate, and I can imagine and know from we employ almost 28,000 people how hard it is for parents who have kids at home whose lives have been interrupted. But when you walk and see the impact of this disease on people, yesterday I was up in the pediatric intensive care unit, and they had just intubated a 19-year-old with COVID. And this child, 19, a child, is sicker than you can imagine. When you see this, the price that we are paying right now to keep our loved ones healthy is what we have to keep focusing on, because until we have a vaccination, until we have better ways of chronic mitigation, I think that, the thing that's working right now is social distancing, is hand washing, is good public health measures, and we've got to stay focused on that.
Thank you, Marna. Thank you for joining us. I know you've got a place you've got to go to. So if you get off, it's me on the screen alone, but thank you so much. And I know everybody in the audience will appreciate your being here. Jon, you and I are in this vulnerable, I won't speak for Marna or Tom, they may not be, but you and I are in a statistically vulnerable area. You can guess that I'm class of 60 or class of 63. What last comments have you got as you have people really thinking about the future of their loved ones, of their businesses, of their kids, and of the country?
Yeah, so a few more remarks. One thing I would have said is just to reiterate Tom's recommendation: read The Great Influenza and see the lessons we're learning all over again. I think one key message out of any model and all the thinking is that this responsibility for protecting public health lies with all of us. And while young people may have less severe disease, although not all, as Marna pointed out, they have grandparents, they have parents, and we all have to do our work here to protect public health more broadly. I think the other message that comes through, and that Tom's speaking to, is we weren't prepared. And as somebody who's been in the public health world for a long time, I think we all knew that we weren't prepared for this and many other problems. And I hope that this will bring a deep look at how to make sure our public health infrastructure is what it needs to be for the future. We're in this for the long run here.
Thank you, Jon. They're lucky to have you in Colorado. We miss you in California.
Thanks, Jeff.
And Tom, do you want to end with some thoughts about, you've looked at this at the higher level, not speaking of any particular administration, but if you were thinking of this maybe almost on the level of whoever the next president is, be it the current one or a new president, new administration, how would you think about how the United States should be doing these issues?
So thanks, Jeff. Maybe I'll just throw a handful of closing thoughts out there. One of them is, it strikes me how much that our different relationships with government authority, and not just our worldviews, but our relationships to those authorities, have crept into our analysis and our coverage of this. And I would encourage all of us to try to set our own biases aside as we perform these objective analyses, and that requires some humility on all of our part. Acknowledging mistakes without significant recriminations in our experts and leaders is really important. And I think we'll find even Dr. Fauci, who's treasured gold, we'll come back and concede later. I'm struck by reading the history of the 1918 flu, all of the very well respected public health officials, the humility in their comments and quotes after the fact. None of them were right or wrong. They just recognized in hindsight the mistakes they made or the things they could have done differently. And I felt that was a very powerful thing. And then lastly, I want to really put a finer point on what Dr. Samet just said, and that is the need to improve our public health system is often misunderstood by people that don't really understand what that term means. It is different from our healthcare delivery system. A doctor and a hospital and the administrators that run that hospital are all part of a healthcare delivery system, and it has its own problems. And their objective is to save individual patients. Our public health system is different and has a population level focus. And in this country, our public health system and our healthcare delivery system has not been sufficiently integrated. And that is true over multiple presidencies in different worldviews. And then I guess I would end with the two thoughts. I'm not a stay home public health only guy, although I raised a lot of early flags because of the experience I've had and the experts who have taught me. I recognize the tension to get back to work, but let's not do it in a way where we suffer all the costs of social distancing and then don't gain the benefits by going back too early. So in some ways, this applies in life in all ways. Patience for the next 2-3 weeks can actually get us there a lot faster than rushing. And I think that's a pretty easy thing for us to all understand. And then to really bolster what Colorado's doing and not confuse it or conflate it with what other states are doing. Remember that there's an instinct, especially among the high school students who are learning big complex thoughts right now, to overly quantify and then add and aggregate solutions. If you, in this instance, get some small benefit, quantifiable benefit out of wearing a mask, that's good. And a quantifiable benefit out of social distancing and mitigation measures, that's good. And if you take 3 or 4 of them and add them together, what you end up with is something that is greater than the sum of the parts. And that's for all of us to remember, because each state and city is going to layer different sets of interventions. We used to call it Swiss cheese. There's different holes in each layer, but if you layer them properly, you achieve a positive filtering result. And so if you see a result that's positive with one solution, you might not get that same positive result with that solution in a different city. So don't be rushing to judgment. Don't be rushing to criticism. Let's make sure our public leaders have some humility and adhere to some of these gating criteria before they run into all their varying different individual cheese sandwiches. Each different cheese sandwich will be just fine with me as long as they follow the baseline standard. And then, please, all of them, hold them to the standard regardless of their party. Make them provide information that's useful to you and your family in understanding this and making decisions, and not information that's useful to the institution providing the information.
Thank you, Tom. And Andrea, I'm going to throw it back to you, but I want to just end it with a thought of my own. And that is how many different fields that students at Choate can be studying it takes to understand this. Tom talked about history and the fact that George Bush actually, though he wasn't thought of as a reader, was a reader. Reading history was hugely important. Science, incredibly important to understand science, not to necessarily be a scientist, but to understand it, to respect it, to know how to rely on it. Math isn't the same thing as science. Understanding these mathematical models and things. International relations, which are a major part of all this, international affairs in our different countries. And I would say, just because of my own particular niche here at the USC, communications. There are so many different fields that are important, and I think that maybe one thing to carry away from this from Choate is, I think you can do them all, you do them all well, and you can produce students who are able to deal with the pandemic when they reach our age.
That's the hope, right? Well, thank you, Jon, Tom, and especially you, Geoff, for a very informative and interesting conversation. It seemed like the perfect storm of technical difficulties, so thank you, everyone, for staying with us. Please stay tuned for some future online programming in our Choate ConnectsUs series, and our next invitation for the next one will be in your inboxes very soon. Have a wonderful afternoon and stay healthy, everyone.
Thanks, Andrew.
Thanks. Bye. Bye all.